This presentation was created by Dr. Donald Jurevich. Today, we're going to discuss palliative care. This is brought to you by the Dakota Geriatrics Program, a geriatric workforce enhancement program sponsored by HRSA. The goals of this presentation are to look at the definition of palliative care, the processes, as well as the impact. A definition of palliative care might be a patient and family-centered approach to improve quality of life by preventing and treating suffering of those who experience a life-threatening terminal illness. What does palliative care do? It's a team approach that addresses physical, psychological, and spiritual needs of the person. It also helps facilitate autonomy and choice. It can bridge the transition to hospice. Recent research highlights that palliative care must increasingly address the needs of people who experience homelessness or belong to marginalized communities. Community-based models help ensure equitable access and reduce barriers that traditionally prevent patients from receiving timely and effective support. When to initiate palliative care depends on multiple considerations, but mostly when a serious illness occurs or a steady progression of an end-stage chronic condition, such as heart failure or chronic obstructive pulmonary disease. A lot of this is defined by activities of daily living dependency, as well as elements that are observed like poor nutrition and weight loss. Also, supplementing your impression for palliative care would be abnormal vital signs or laboratory tests. New evidence demonstrates that patients on maintenance dialysis often receive palliative care very late, despite clear benefits. Clinicians are now encouraged to initiate palliative discussions earlier in kidney failure to better support symptom management and align care with patient preferences. The question becomes when to initiate or revise an advanced care plan. Those allow us to define the goals and preferences for medical treatment and care. It also helps communicate the plan with family and providers. Ask your patients, have you talked to your family members about your living will? You also want to document the advanced care plan. Many times, people will have living wills, but do not have that documented in the medical record. It's important to understand who the healthcare proxy is for the person. For our first polling question today, we would like to know, which of the following is a key indicator for initiating palliative care in patients with serious or end-stage chronic conditions? A. Routine annual physical exam without symptoms. B. ADL dependency. C. Improved appetite and weight gain. D. Normal vital signs and lab tests. The correct answer is B. ADL dependency. The question is, how does palliative care, as an entity, support patient and family? Firstly, it's a team approach, and it helps with listening, communicating, and further supporting decision-making processes. It helps bring focus to goals that are obtainable. It should strengthen coping skills of the patient and family members. It also will help facilitate conflict resolution. When that occurs, it will also encourage completion of unfinished business. It really provides a perspective of taking things one day at a time. Recent trials show that exposure-based behavioral therapy can significantly improve dyspnea, anxiety, and overall mental health in lung cancer patients. Incorporating these approaches into palliative care can reduce suffering and enhance quality of life. Palliative care is coordinated care. It helps integrate curative disease, modifying, and palliative care options, sometimes which are all occurring simultaneously. It also helps with symptom management, providing comfort and helping the patient meet goals. It may involve healing relationships, and at some point, it may contribute to bereavement support. The forthcoming 5th edition Palliative Care Clinical Practice Guidelines emphasize enhanced interdisciplinary coordination and person-centered care across all settings. These updates reinforce the need for integrated teamwork to ensure high-quality, equitable care. What are the time points of communication? There's the initial diagnosis and prognosis of a limiting lifespan. We discussed the trajectory of that disease process. And also other points of communication include updates when there's a change in status, whether that occurs through hospitalizations or transitions to long-term care, or perhaps even to hospice care. Recent reflections on the COVID-19 pandemic underscore the importance of proactive, transparent communication during system pressures. These insights continue to guide how palliative care teams maintain continuity and emotional support during rapid clinical changes. There's various terminal conditions. Look at their trajectories as well as their palliative care needs. Cancer seems to be an obvious one, which might be a situation with short-term survival. With widely metastatic disease, a lot of treatments for cancer now have really advanced the science and treatment of cancer. It's not always a foregone conclusion that somebody is terminal when they have a diagnosis of cancer. For those that do have advanced disease, it's important to understand pain control, exploring the option of hospice, and preparing both the patient and family through palliative care. By contrast, chronic conditions such as heart failure and COPD are much more roller coaster events where you get acute exacerbations followed by a period of recovery. These come and go. Overall, the trajectory is one of a downhill decline. Knowing the point of the end-stage disease is when both palliative care and hospice would be appropriate. Neurodegenerative disorders are another consideration for palliative care. These involve typically a steady decline in function. For example, we know that Alzheimer's disease has a 10 to 12-year trajectory. That trajectory is accelerated by extrapyramidal symptoms, such as Parkinson's syndrome. That person may have only 8 to 9 years of life expectancy. We use a variety of tools to help predict those trajectories. One is called the Functional Assessment Tool, or the FAST, for Alzheimer's disease, and then for neurodegenerative disorders, we can use the Palliative Performance Scale. For other conditions, such as stroke or traumatic brain injury, these represent more sudden loss of function and can really have remarkable impacts on families and their coping strategies. Palliative care may be appropriate, particularly to help the family and patient understand that there is a 3-month window of initial recovery, where about 68% of what is recoverable occurs with smaller gains in functional recovery, whether it be cognition or physical improvements that occur over a 12-month period. It's important for us to remember the spike's mnemonic. It's communicating bad news. We look at the S for setting. Have a private place. Have your information ready to share with the patient and the family. You also need to understand the perception. How does the patient see their illness? Based on that, have an invitation. Really understand from a provider's point of view how much the patient wants to know. K is for knowledge. This is to deliver information to the patient and family in non-technical terms. E is for emotion, allowing the patient to express their feelings and to acknowledge those feelings as a provider, and then finally to summarize. New literature shows that applying the SPIKES framework in culturally diverse or resource-limited environments requires additional sensitivity to cultural norms and systemic barriers. Providers must adapt each step to honor the patient's social and cultural context. Polling question number 2 asks, in the SPIKES mnemonic for communicating bad news, what does the K stand for? A. Knowledge. Deliver information in non-technical terms. B. Kindness. Offer emotional support immediately. C. Knowledge. Use technical medical jargon for accuracy. D. Keep. Summarize the plan at the start. The correct answer is A. Knowledge. Deliver information in non-technical terms. In looking at prognosis, it's valuable to use validated tools, such as the Palliative Performance Scale, that can be coupled to the Prognostat tool, which is developed out of Australia. In the United States, the e-prognosis calculator helps identify trajectories for many chronic conditions. There are also chronic disease calculators, such as the Seattle Heart Failure Estimator, and for Alzheimer's dementia, the use of the FAST scale. Recent work highlights the complexity of prognostic conversations in diseases like glioblastoma, emphasizing staged, ongoing discussions rather than single prognostic statements. This approach helps families process evolving information more compassionately. It's important to document things, such as the advanced care plan. About 50% of patients generally have this documented in their medical record, and quite a few more may have advanced care plans and living wills, but they are not documented. It's important to establish who the durable power of attorney is, and to always ask patients whether that information is changed. For POLST, the physician orders for life-sustaining treatment. These are documents that are supported by each state on a state-by-state basis that provides information about whether the individual wants cardiopulmonary resuscitation versus a DNR status or do not resuscitate. It also lists the level of medical interventions, whether they want just comfort care, limited care, or full care in case of an emergency. It addresses issues like the patient preference for artificial feeding and hydration. Emerging global studies reveal that implementing living wills remains challenging in some regions due to legal and cultural ambiguities. These insights remind us that documentation processes must be clear, accessible, and culturally sensitive. We know that palliative care is impactful. It can help reduce costs in the acute care setting. There's some data that suggests that 80% of all Medicare costs go to the final year of life. Palliative care can be one way to alter the trajectory of both costs and then also quality of care. Implementation of palliative care improves symptoms, reduces the symptom burden, reduces pain, and overall improves patient satisfaction. Now, let's take a look at a case study of how palliative care can be integrated for a patient with end-stage heart disease. Patient background: Roseanne is a 78-year-old widow living alone in a retirement community apartment. She has a history of severe pulmonary hypertension, valvular heart disease, osteoporosis with spinal curvature, alcohol overuse, and a large hiatal hernia restricting lung capacity. Recently widowed after caring for her husband with dementia, she experiences isolation and anxiety. Her 2 adult sons live far away and visit infrequently. Presentation and initiation of palliative care. Following a hospitalization for respiratory distress, Roseanne was discharged on continuous oxygen therapy. She struggled with adjustment, experiencing frequent shortness of breath exacerbated by anxiety and exertion, especially at night, severe fatigue, poor appetite, and emotional distress over losing independence. These symptoms led to repeated 911 calls and emergency department (ED) visits, indicating ADL dependency and poor symptom management. Key indicators for palliative care initiation in end-stage chronic conditions like heart failure. Her primary provider, recognizing the progression of her illness and unmet psychosocial needs, referred her to a community-based palliative care team. Palliative care process. Using the SPIKES framework for communicating prognosis, the team met Roseanne in a private setting to assess her perception of her illness. How do you see your heart and lung conditions affecting your daily life? Invited her input on information needs, delivered knowledge in simple terms, for example, explaining disease trajectory without jargon, acknowledged her emotions, frustration, and fear, and summarized a plan focused on quality of life. Prognosis was estimated using tools like the Palliative Performance Scale, highlighting a likely downhill trajectory with potential for acute exacerbations. The interdisciplinary team, nurse practitioner, social worker, and collaborators, addressed physical, psychosocial, and spiritual needs. Symptom management. Adjusted medications for dyspnea, mood, and appetite. Taught breathing techniques, for example, handheld fan, incentive spirometer, and a stepwise action plan fan to spirometer to low-dose morphine to 24/7 nurse line to prevent crisis. Autonomy and goals. Facilitated a video call with her physician and sons to define attainable goals, such as maintaining home independence. Completed advanced care planning, ACP, including a physician orders for life-sustaining treatment, pulsed, documenting preferences for CPR, medical interventions, limited care, and artificial nutrition or hydration. Support and coordination. Provided regular home visits, physical therapy for strength and balance, a portable oxygen concentrator, and counseling for grief and adjustment. Coordinated with her primary team to integrate curative options, for example, ongoing cardiac monitoring with palliative support, while addressing potential transitions to hospice. Outcomes and impact. Within weeks, Roseanne's shortness of breath, anxiety, and appetite improved, allowing her to resume activities at her senior center and church. She gained confidence in self-managing symptoms, eliminating unnecessary 911 calls and ED visits, reducing healthcare costs, and aligning with research showing palliative care lowers end-of-life expenditures, for example, mitigating the 80% of Medicare costs in the final year. Her quality of life enhanced through strengthened coping skills, family communication, and a one-day-at-a-time perspective. Roseanne stated, "Palliative care helped me live my life, not just struggle through the day." This avoided long-term nursing home placement and honored her preferences, demonstrating palliative care's role in equitable, patient-centered support for marginalized or isolated individuals. Key lessons. This case illustrates palliative care's definition as a team-based approach to relieve suffering in serious illness. Early initiation based on indicators like ADL dependency and symptom burden, combined with tools like spikes and pulsed, improves outcomes, reduces costs, and facilitates transitions, reinforcing the presentation's goals. In summary, palliative care provides patient and family-centered options to relieve suffering from physical, psychosocial, and spiritual distress. It's impactful. It improves both the quality of care and reduces healthcare costs. It's important to utilize the mnemonic spikes when delivering bad news and to use prognostic tools to help patients and family members understand the trajectory of their condition. Thank you for your attention, and please visit the Dakota Geriatric website for additional presentations on geriatric topics.